All right, so thanks everyone for being here. Just to go over the this structure of everything. So we didn't have a name for it before, but now we're calling it the Cross Canada Checkup, PT Cross Canada Checkup. And really it's an opportunity to connect with physios across the country to see what types of initiatives are happening in different communities, to share the situation that's happening in terms of COVID-19, and to really brainstorm and talk about some of the solutions that we can come up with together. So the structure of these sessions is we have Michel Landry goes through a situation report or a sit rep. So it's kind of run like what would happen in any kind of humanitarian crises or disaster response. And then we have an incredible guest today. So Michel Sangster is here, and I'm going to introduce him after Mike does the sit rep, but I am really excited that he's here. He's got an incredible amount of experience, not only with what's happening right now, but also just in global health. And he's developed some really, really amazing initiatives in terms of looking at the scope of physio and seeing where we can have an impact in pandemic response. So I'm really excited about that. So I'll pass it over to Michel Landry for a sit rep.
Yeah, thanks, Phil. Yeah, just to underscore, we just had a little pre-Zoom meeting chit chat with Mike here, Michel Sangster, and I mean, not that we should look at all the positives, or maybe we should, but connecting with Mike has been super. One of our Phil and I's huge positives over the last couple of weeks, and thank you, Michael, for being here today. And I think what's important also, just to underscore, is that I'll provide a little bit of an update in a minute, but what's important is that it's a two-way street. So we're super, in fact, probably what's more interesting is to find out what's happening in the field around the country. And that's what this whole Zoom meeting is all about, is finding out from people like Mike and everyone else. And I'll be honest, I don't know if Stefan is on this, but I'm still haunted by his voice and his scenario from a couple weeks or a couple days ago. So I think the real power in all this is the conversation. And so Mike, thanks for being here, and we're going to pass it to you in just a minute. Phil, thanks again. I'm just going to share my screen a little bit here.
Maybe just before you move on to the sit rep, I can bring up a little bit of the initiative too.
Sure. Yeah, go.
So one of the things that's been going on behind the scenes that we'll be moving forward with the Canadian Physiotherapy Association is the development of an emergency planning task force. And really the idea behind this will be to develop a coordinated response for short, mid, and long term. And what we've really been pushing for, and what's a critical component of this, are these discussions. And really so that we can get an idea of what's happening, what initiatives are occurring, and just like Mike said, really get an idea of what's going on the ground so we can feed that up into this task force. So just to touch on that a bit. Okay, back to you.
Yeah, no, thanks for, I actually tragically completely forgot to mention that, but yeah, no, thank you for that. So this is happening as we speak. Previously, JP and Vivi in their address talked about this task force that is created, and Phil and I are super involved in this. But please know, it's not just Phil and Mike, it's all of us. This is like a hashtag, all of us. So we're hopefully going to reach out and have info that's going to be pushed up and pushed down and laterally, all for the reason of what do we do over the next few weeks. Just before I even share my screen, I think you all probably saw that there quite a high number, a progressive number that's happening in Canada. It camouflages in some ways the huge numbers that are happening in the United States. For instance, last Friday in New York City, there was a call from the governor looking for any state that would have additional ventilators, and the number was 30,000. They were looking for 30,000 additional ventilators. So that told me a couple things of the challenges around pre-preparedness, which, it's not a blame game, but it's just an understanding of where we are. But secondly, there is no feasible way New York City or any city in North America will get those kinds of numbers of ventilators. So think about the role of respiratory physical therapy. Where do we place? How do we improve that throughput? How do we improve the efficiencies in the ICU and otherwise? So the numbers are big. I'm glad to see that the Canadian Physiotherapy Association is creating a task force. By the way, I'll say that there is a other side to this. So within the American Physical Therapy Association, there is a great leader called Heidi, who is going to be our compatriot here, our comrade. So we're going to be actually creating North American pre-preparedness planning to get us through this current COVID, but also think about how we look into the future in terms of a North American strategy. And maybe one thing that we might have is additional resources to allocate to this. And so certainly we're looking for ground up and everybody to participate. So I'll stop there, and then I'm going to start to share my screen. I want to show you something, show our community something that's important. Phil sent me to here. So again, this is just the Government of Canada. This is the Public Health Agency. Created a really interesting new mapping. So you can go to any different province, territory, you name it, to look at different numbers. Now, I will say that I'm quite shocked. We are quite shocked at the rapid increase of the numbers that are happening in Quebec. If you look here, what we have is a fairly large number, especially if you look at the other highly populated provinces. So if you were to click on, for instance, you get some more details. But ultimately, here's our curve. The curve remains, if you look at Newfoundland, New Brunswick, you get a real-time number that's happening across different provincial and territorial jurisdictions, which is important because even if Phil and I planned this sit rep within the last few hours, our numbers would be wrong, which is completely different than a disaster or a conflict zone where we've worked in the past. So the numbers are moving. So what we really want to underscore is go to the Public Health Agency of Canada, go to the Government of Canada. They, especially in comparison with other governments, have really good information. It certainly seems as the federal part as well as the provincial and territorial part are communicating. And so these are very blunt numbers out there. So we're just sending you that way. A couple things that may have been occurring over time that I think I'd like to maybe highlight for British Columbia. The public health, the top public health agent, the public health physician, I can't recall her name at the moment, but came out on Friday talking very, very clearly about don't be super positive about this, but it seems as though the physical isolation has helped to quarantine or to lower the spread. So British Columbia are seeing a different curve than we are in Ontario or other provinces. And they are allocating this, it's a little bit of a causal link at this point, but they're allocating this to the quarantining approach. This gives me an opportunity to maybe mention the fact that South Korea, Singapore, and it seems as though China have and are reporting lower new infections than they were of just a few weeks ago. Mostly, again, allocated to the ideology of isolation and quarantining. So all this to say that, some of the new numbers and some of the new policies coming out of Ottawa in terms of the Trudeau government are really around reinforcing some of these quarantining and policies. The point here, though, is that, on the one hand, from a public health perspective, we have your numbers there. I'd super encourage you to go and look a little bit more and what those numbers mean to you. But they seem to be working. The public health approaches that dated 300 years ago during the plague seem to be working. So let's all be the stimuli of change as PTs. Let's do the right thing. Let's be the people who others look to do the right thing. But also, let's look towards some of the really innovators out there. And Michael, this is sort you up here, but Michael in Halifax has been doing amazing work so that, there are roles that physical therapists and physiotherapists can play along this trajectory, including students, including assistants, as you move forward. So before I even pass it over to Michael, let me just say a couple things. We have heard, of course, since our last sit rep that British Columbia and Quebec have launched their rosters. So if you're in BC, if you're in Quebec, there is a launch from the regulatory authorities so that you can sign up and move towards volunteerism, which Phil and I super support. And now, if for instance, we're not sure of how that's all going to work, and nor do we have oversight, but if you feel like you require a little bit, or you self-assess that you require a little bit of further education or con ed, come to us. We have a website that's soon to be launched. We got some content that's going to be there that will position you to be effective into the field. So Phil, maybe I'll send it back over to you. That's the main point. I think what's really important is that this is moving so fast, Phil, that we can't give numbers. I think it's more important that we send people to the Public Health Agency of Canada to start looking at what the reports are. So I'm going to stop there and pass it over to you, Phil.
Yeah, absolutely. And it kind of goes back to one of the things that you were saying. I think it was in a previous webinar or in a podcast, but just that one of the most important things we can do right now is to be kind of an example in terms of behavior as professionals, but also in terms of sharing information that's reliable and consistent. So yeah, I completely agree with that. So thanks for that, Mike. So now I can't stress how excited I am. We have Mike Sangster here. So I'm going to introduce him, and then I'll let him tell us about his initiative and some of his work. And then we'll open it up for discussions and Q&A at the end. So Mike is the founder of Project Next Mile, or PNM. It's a nonprofit organization that serves to strengthen clinical and local communities globally through a build with approach to partnership. Mike is passionate about global health and travels annually to resource-scarce regions of the world with Project Next Mile. On his travels, he was twice fulfilled the North American amateur soccer player's dream of being invited to play soccer with locals in both Peru and Rwanda. He's hiked the Inca Trail, and he's braved the perilous tuk-tuk rides in the back streets of Bangkok. He's played cricket with children in Dharavi, India, swam with sharks, rescued a puppy from a Caribbean beach, and survived dengue fever. So Mike is also a physiotherapist on the pediatric complex pain team at the IWK Health Center and a clinical specialist in pain science. He's a graduate of Dalhousie University School of Physiotherapy, the Masters of Business Administration program at St. Mary's University, and the Doctor of Public Health Therapy, or Doctor of Physical Therapy program at Utica College. Mike also serves as an adjunct clinical associate at the Dalhousie University School of Physiotherapy, a member of the Health Canada Canadian Pain Task Force, contributing author to the Oxford Textbook of Pediatric Pain, and has given TEDx talks entitled Finding Your Place in the Beautiful Game. So I am extremely excited to welcome Mike. As you can tell, he has a ton of experience in global health, also professionally as a physiotherapist, and just in chatting with him before is just a great person. So welcome, Mike. Thanks for being here, and I'll pass it off to you.
Thanks, Phil. I really appreciate that. Everybody hear me okay? Sound is good? Excellent. So I'll talk a little bit about what we're doing in Halifax, which I think is really relevant across the country and probably across jurisdictions across the world. I want to start by saying, and I heard you say, talk about my initiative, and I think it's important to start off to say that it is something that I'm doing to get our physios engaged in or stepping into, I think, what I would call an optimized role. But it's really the physios that are the heroes here, so you need to know their names: Kylie Woods, Allison Reed, and Alexis Lister. So it's not Mike Sangster, it's those three who put up their hands first to do this work. and they're the ones that need to be celebrated, not me. So so with that, I will tell you about a little bit about our initiative. And it really comes down to, I think at a time like this, I think we need to do this anyway as a profession, but at a time like this, we really, sort of take an introspective look and say, how are we similar to our colleagues in other professions? How can we work in a collaborative or interprofessional way? And that's where this started. Our health center wanted to set up a COVID assessment site as a part of the provincial mandate, and they were staffing it with RNs and LPNs, so what we call licensed practical nurses here in Nova Scotia, and then registered nurses. And I took a look at what they were doing and thought, we can do this too. And there are lots of things that we do similarly to our RN colleagues or our LPN colleagues, for example, but there's some things that they do that we don't. So they'll administer medications in a critical care unit, for example. And it got me thinking, and of course, what's happening in the rest of the globe gives us a bit of a foreshadowing of what could be, down the road in terms of the demands on the health system. And I thought, if we need to redeploy nurses, should they be working in an assessment unit, or should they be redeployed to floors where we need them? And in particular, if a large volume of nurses are sick, we're going to need every single one. So I went forward and thought, maybe we can do something in these assessment clinics, and really took a look at our scope. And for most acts across the country, I think, certainly in Nova Scotia, we are permitted to do nasopharyngeal suctioning, right? In fact, the acts often state something to the effect of, we have the legislative authority to pass an instrument through the nair to the pharynx. So an instrument is the key, right? Now, we tend to think about that as a suction catheter, but it's an instrument. And so at that point, we were talking about doing nasopharyngeal swabbing as a component in testing, when in fact it's not even that. It's an oral pharynx swab followed by a swab in the nair. So actually even more benign than nasopharyngeal swabbing. So and taking vitals seem to be the prerequisite skills to be able to be deployed to a COVID assessment unit. And so I talked with our registrar, a great registrar of our regulator, and I found in Nova Scotia we have an excellent relationship with our regulator, where we can have good conversations and problem solve together. So I would encourage PTs to engage with your regulator. We're all on the same team, really. So that's what we did, had a great frank discussion and about this, and asked whether this is something that we could do, got her opinion, and she agreed that this was something that we could do. We needed to work with our policy folks in our institution, write a care directive, which is a public document. So Phil, I can make it available when it goes when you're looking for resources for the website. Certainly can make that available. We wrote a care directive in collaboration with our nursing colleagues and our respiratory therapy colleagues, which is awesome, and included physiotherapists on the list of potential clinicians who could work in the COVID assessment unit and perform the assessments. And then, of course, in order to prepare our physios and to fulfill our obligation for competency, we developed a competency development program. So we did all this in about 5 days. Developed a competency development program, which was led by one of our nursing colleagues who came, who instructed us in how to do the swabbing that we needed to do. We looked at a number of publicly available resources too, which again, I'll make sure the link is available to you, Phil, that went through policy and different things that one would need to know to fulfill the role in the COVID assessment center, and things like PPE. So we ran a competency session, invited our physios. They came and we did it. We rostered them, sent it off to the appropriate director, and said we're ready to go. And then people volunteered. So the names of the individuals I gave you, Kylie Woods, Alexis Lister, and Allison Reed, volunteered and said we will go. right into the middle of this. So I think they deserve a lot of credit, and I think they've pioneered a role for physio here that we otherwise wouldn't have thought of. So it was as simple and as complicated as that, right? To get us to that place. And so all of those 3 individuals have taken shifts in the COVID assessment unit. They're very comfortable. We have a team huddle 3 times a week, and they come and they've reported back on what's happening in the COVID assessment unit. We've rostered in our small little group of physios of 17.2 FTEs. We've rostered 12 or 13 physios, and we're going to do a rotation as this goes on, so that they'll be in the assessment center for a month, and then they will rotate out and back into clinical practice, the clinical practice pool, and others will rotate in. And what's most important here is that the clinics are currently staffed by 4 clinicians. So 3 RNs and a PT at present. But what we are doing is building capacity in our people to be able to hopefully expand that. So it could move to 1 RN and 3 PTs, for example, if those RNs need to be redeployed. So I think it's a great example of PTs doing their part on an interprofessional team to ensure that resources are where they need them to be as we move forward in the management of this pandemic. So there it is in a nutshell.
Incredible. Thank you for sharing that. And really, like, the first thing that comes to mind is just this is thinking out of the box. This is, it's global health, and I can tell something that really came out right away was that I can tell your experience in global health and all around the world, because you said, this is something that you did and you got organized in 5 days.
Yeah.
And it's something that I kind of keep coming back to, and I've heard a couple of times now, is that an emergency means now. And you're definitely showing how we can act quickly, and we have the capacity to do this. So it's an incredible program.
And I think one of the things we need to consider, and I'm stealing this from a quote from an emergency management official who would have way more experience than me, and it was, in an emergency, we're looking for good enough, not perfect. And I think that was our approach to this, to try to innovate this, was to say, okay, how do we check the boxes, but we don't have time to make this perfect. It will evolve. We're building this plane while flying it. And we'll make decisions, and we'll have to make fixes, and one of the things that I've always said to our team is that we're after the minimum viable product when we're innovating. So if we were building an app for an iPhone, we'd build version 1.0, we'd launch it, we'd find the bugs, we'd fix it, and we'd launch version 2.0. We'd constantly be iterating here. So what we sought out to do was, what is a minimum viable product that's going to keep our people safe, right? That being a key criteria here, and be able to make a difference in a very innovative way, so that we can really be a part of an interprofessional team and free up people where we need to, and go where we are capable of going as PTs.
Yeah, I like that of the minimum viable product, and like the app, version 1, and figure out the bugs and go with it. Yeah. So now you mentioned, so it also seems really interprofessional. And so how has it been going? Like, how has it been received by either the people that are coming in for the assessment, but also the professionals that you're working with?
So the feedback that I've gotten from the 3 PTs that are in the assessment center is that with the individuals that are coming in for testing, I don't think they even know. Everybody's wearing blue scrubs. We're all the same, right? And I have said on social media and other places that one of the interesting things about now is that people are wearing scrubs and doing different things, and the things that used to identify us as particular professions, that we're starting to tear those down, and we're just all in it together, which is really an interesting phenomenon. How that in my health center is changing. So I would say that extends to the work with the clinicians. So the PTs that are again in the clinic are saying that the RNs that they're working with are fantastic. We've got a really good working relationship, and they're really all doing the same job.
Yeah.
That's in the end, which is just a fantastic opportunity for us to step in at this point.
Yeah, for sure.
Hey, Mike, and maybe Phil will open it up to. I'm sure there's a lot of folks who have a question. I think maybe you, me, and Phil, and many on this call are like mothers or the sons of another mother, or whatever the saying is. I mean, we're totally drinking on this. This is awesome. How did you do it? How do we scale this across the country?
That's, I think jurisdictionally, one of the things about Nova Scotia is that we're small. So we're 1 million people. I know Joan Ross, our registrar, personally. It was really easy to pick up the phone and say, and the conversation was, Joan, I've got this idea. I think we can do this. What do you think? And we sort of batted back and forth on what we needed to do to make it a go. And in real time, I was sending her the care directive document that will be available, and saying, read this. What do you think? Does this, does the words here work? Is this gonna fulfill our legislative requirements? So I think that if I'm being honest, although I can't speak for the bigger provinces, I think that sometimes gives a smaller province an opportunity, because we're a little bit more maybe nimble or agile. Right? There's 800 physios in Nova Scotia. Having said that, I think that we've learned a lot in our process, and to scale it up, I think, is to I don't know if it's by health center or by or at a Department of Health level, to say, look, this is capable of being done. But I think each province obviously needs to have their regulators on side, and that the regulators need to ensure that this is something that falls within the legislative scope of practice by province, which we know differs subtly across the country. But if we look at the Conference Board of Canada, I think all physios have as an authorized act nasopharyngeal suctioning, and if that's the case, then this is more benign than that. So it is the kind of thing that I think we could be able to scale up quickly. But we need the regulators at the table for sure, because this is, it's new and different. But I think that people are, certainly Nova Scotia, I felt like people were ready for innovation, recognized the need for it, and we can get a lot done in a short period of time, given the need for innovation.
Well, thank you. Let's pass it over to Diana Hopkins-Rosil, who's got her hand up. But just before we pass it to you, Phil, what I'm thinking is, given our new connectedness inside of CPA with the task force, is reaching back out to Mike, but thinking, how do we use some of these examples, not to inform, tell, push, but to just elucidate what we're doing, or what PTs around the country are doing. And I think what you've done, Mike, is some pretty amazing stuff. So, but there are complexities, as you mentioned. I mean, smallish environments, you can pick up the phone. Can't really do that the same way in British Columbia, where the other kind of major numbers are happening. So maybe as a message for us, maybe we create a little bit of case studies, or examples of where things are working, and sort of a checklist of 1, 2, 3. Here's how you get to it. But Diana, we'll pass it to you. But I think you brought up some major points there. Thank you, Diana.
Yeah, truly amazing. Holy toot! So glad I was able to come on. Mike, I just have a couple of questions, as in Mike Sangster. This is great. One of my questions is, how much local buzz, as in local media, anything even at the hospital, how much has been generated about physios being a part of something like this? So that's my first question. Have any, so local media, and has anything been pumped out about this on the wider social media?
So the short answer is not really. I think in social media, some things have been pumped out about physios stepping in, and the role of physio, and the role of physio in a more conventional sense. So we do have and our critical care physio and our acute care physios, inpatient, and then we will have a pandemic response unit at our health center, so they will be staffed there as well. So so that's sort of out there on social media, but there hasn't been anything, I think, in the local media about what we're doing here. So so when I first chatted with Phil, I said, this is a story I think that needs to be told. So I have my vision here, I guess, would be that that my three heroes, Kylie Woods, Alexis Lister, and Allison Reed, are on the cover of some CPA publication as showing what the profession is capable of somewhere down the road.
Which
So,
is awesome. I'm
yeah.
going to suggest that in the shorter term, and to take it wider and broader than physios, which I
Yeah.
think is important. And it speaks to my pissing and moaning all the time about, being called allied health. We're not allied health, we're health, just like everybody else. We have to stop using that terminology. Well, it's the same kind of thing. It speaks to me about right now, in the moment, getting the message out in several ways. Like, I tried to call into CBC's cross-country checkup,
Mm-hmm.
because they were saying, who are your heroes? And I thought, you know what, I'm going to call up and say, the physios who are out there and look like everybody else, but underneath it all maybe have some complementary, some same scope, and some very distinct scope things that are happening right now, right? And you just listed them beautifully, way better than I could have. And I got sort of 3 away from being on, and then show was over. But this is the kind of thing that CBCNN and CBC, they're just clamoring for this stuff. And you're a very gentle-spoken, what I would perceive, all 3 of you gentlemen, as great spokespeople for this kind of a thing. I also think it speaks to, and I'm sounding like the squeaky wheel to Mike and Phil, but this is something where you take a picture of everybody at the COVID testing center in their PPE, and then another picture afterwards with the PPE off, saying, I'm a physio, I'm a nurse, I'm an RT, we're all in this for you guys together. And put the PT in the center. And and like right away, as the complex pieces of how do you get this happening across the country are percolating in the background, that kind of thing. But to me, this lends itself to shout it from the rafters, jump off that cliff, that kind of thing.
Mm-hmm.
Leave it up to Diana to stir the pot as always. So Diana, I'm taking notes here. No doubt Mike times 2 and Phil are on your side here. So we'll take this back to CPA and see if we can really promote this, but not just as a this is what's happening, but how it happened. Step 1, Mike, I'm hoping you would help us here, step 1, step 2, step 3. So that if other areas want to replicate it, I think there is a recipe. It's not rocket science. It's just a recipe. It's like moving forward in different ways. So excellent points, Phil. What do you think? Should we bring this to CPA?
Absolutely. I think that Mike Sangster should be part of that as well, because I think when Mike we chatted for a bit, and one of the things that really stuck out was that it was not only was it an incredible initiative, but that he went through the right steps in terms of making it happen, and he managed to make it happen very quickly. So yeah, I think this definitely needs to be brought forward to the CPA and nationally as an example, and we can try to push it forward.
Seems to me that the one thing that you had, Mike, and you talk about your 3 leaders there and keep forgetting to mention yourself, but is that you had some individual, and I would perceive that's you, who championed the first step. I would see this as difficult in getting all the pieces that you're going to list in a list, do this first and then do this and do that. When you say you do this, What's going to happen is there has to be a champion, whether it's a champion in Ontario and that happens to be OPA that starts and then filters through the districts or something, or whether it truly is, you've got online here somebody from Napanee in Ontario, somebody from Kingston in Ontario, you've got Jen O'Neill and so on, and there are just people out there listening right now who maybe because they're online they would be champions as well. But that's probably one piece where you need that person who's willing to move. How did you put that? It doesn't have to be perfect.
Yeah, it's good. We're looking for good in emergency management. We're looking for good.
Yeah.
Perfection's the enemy of good.
Yeah. Okay.
Good
I'll go
Good
off now.
So I appreciate that, and I think if we think about, we had this conversation before we started recording just about global health, and I've done a lot of global health work, and that, if nothing else, has changed my perspective from, instead of we can't do that, to why can't we? And so from because oftentimes in resource scarce environments, the same job has to be done with a lot less. So we have to find a way. We have to problem solve. And sometimes, in my global health world, some of my best physio has been done while trying to problem solve something. When you think we have to get to this end point, and I don't have anything that I need to or would have in my my hospital in Halifax. How are we going to get there? And trying to figure that out because it's necessary. So that has changed my perspective, and I think that's what the champion needs to be, is to say, why can't we? So when we set up the COVID assessment unit, I asked how the assessments were happening, what needed to be done. And when they explained it, I thought, oh, why can't we do that? What's stopping us? And in fact, nothing was stopping us, but for a legislative consultation with our registrar and the college, and a number of policy documents, which I'm sure is happening across the country right now. What used to take 12 months to get through from a policy perspective is now, flipping around really, really quickly, which is, provides an excellent opportunity for us to step in and to do that. So I think, not to sound, too, I'm not sure what word I'm looking for, too high level about this, but it's, the champion needs to be somebody who has that why can't we perspective.
Let me just add to that, Mike. The other really important point is, and I know this is a little controversial in a moment of disaster or emergency response, but how do we measure it? How do we make sure that there actually was an outcome, or like what were the outcomes? How do we plan for it? We have to get a little academic-y on this, because COVID-19 is the first one. There are many more to come, and so how do we prepare? How do we really create a robust environment for the preparation phase? So what would you kind of reflect on that in terms of maybe research, but more on the preparation phase? Were you guys ready for this?
Were we ready for it? I think, again, I would say I or our group has taken advantage of the fact that we're small and nimble. And how I would say we've prepared. So I'm the professional practice leader for my group. So I guess responsible for the practice development for the PTs in our institution. And we've always had a practice plan. So we look at our institution's strategic plan. And what I've said to the group is we need a practice plan that mirrors this, so that if you get on the elevator next to the CEO and she asks you how you see yourself in the plan, you can give her an answer between the floor you got on and the floor you get off, right? You've got to have that elevator pitch ready. So so that's what I've always said to our group. And then I follow that up by saying what we need to do is to step into necessary. And, as a group, we need to step into necessary. I think a lot of times, and Diane, I appreciate your comment about allied health. I'm with you. We're health. That's it. But in in what is conventionally known as allied health professions, there is a temptation to see us as nice to have, and we're not nice to have, we're necessary. So I say that to my group, step into necessary. And so on that, I think that our small little agile group of 17.2 FTE said, yeah, okay, this is a way to step into necessary, right? So in a sense, we were prepared to step into necessary, and everybody was game to do that.
That's amazing. It sounds like, I saw Mike Landry just quoted that, step into necessary. And it sounds like some of the structures that you even built in place within your group was to allow the opportunity for innovation and really encouraging innovation when it did present itself. So that's, I think, like, we're lucky that we have you in our profession. So that's absolutely incredible. Yeah. I think, were there any other, I'll open it up to the floor for more questions and any comments for Mike?
Hi, Mike. This is Jen. First, I just wanted to thank you for inspiring us to be leaders. So, and congrats on this initiative. I guess one of my questions for you is, being from Ontario and Ottawa, I can't just pick up the phone and call regulators. How would you go about to use what you've learned so far so I can convince people, at least at some of the sites I'm working at?
So great question. I think what we'll do is, Phil, actually, I keep saying I'm going to make it available to Phil. Phil, I already think sent you or we talked about the link where you can get all the documents, but I'll make sure that I send it to you so that it can be posted. And I think that, so I would suggest that, Nova Scotia paved the way a little bit. There will be Ontario or BC or Quebec or whatever subtleties, but the road is paved in terms of documentation. So that's the first step in a particular institution. I think would be to go to the practice leader or whatever the equivalent is for physiotherapy and say, look, this is being done, and this is something that we could do too, and here's how. I think the other thing is that there, again, as I've said, there's advantages to sort of growing up in a small place and being able to reach out. But Ontario is still a small place, and if you look at your board of directors for your college, there's somebody there. Somebody knows somebody. Physio's not that big a community, right? And I would reach out to that person first and say, how do we get this in front of the right people, right? In particular, the bigger province like Ontario, how do we get this in front of the right people, and let the board member take it from there, perhaps, right? That would be, if I were in Ontario today, that's what I would do. I would go through them or somebody else that I know on a committee, somebody that has a connection somewhere, and go forward that way and get it in front of the registrar. The registrar really needs to, or the regulator needs to, give their legislative perspective, just to make sure that it really is something that falls within the scope of practice in the respective province. But when I look at the national documents, we all can do nasopharyngeal suctioning, and if we can do that, you can stick a Q-tip in someone's nair, which is the extent of what is required, right?
Thank you.
You're welcome.
So any other questions or comments from anyone?
If it's okay, I do have a question. So I was going to ask the same question as Jen, but then I was thinking that if I were to email the register even today and just say, hey, I was on this webinar, and give them some details about what's been happening in Nova Scotia, and just say I would follow up with a phone call this week, or if they'd like to call me, they can. And then start it that way before going, I guess, to the healthcare center. So if I was able to talk to the College of BC, then I am more directly involved with interior health in BC. So I could probably help to initiate it there, but then BC has 2 or 3 other health, I guess, jurisdictions. So I don't know how complicated that would be in getting things set up.
And I think it does make it a bit more complicated. I would suggest, though, if you can start small and scale from there. Start small, get some successes, and say, look, this is happening. And I think this one of the single biggest successes is to say, in your particular facility, rather than having to have 1 or 2 or 3 nurses that have to staff a particular assessment center, those can now be redeployed to a place where they need. And that is a very positive outcome, because there's things that RNs do that PTs don't, and there's things PTs do that RNs don't. But we need RNs to be able to staff these units. If we're seeing COVID patients, or other patients for that matter, on them, because we know that it's not just COVID-19 patients; it's the lack of resource to care for the patients we would have seen anyway, right? So we need to make sure that we're able to free up that resource. I think, given that, I certainly in my Nova Scotia experience, we've got a fantastic registrar here, but I think she saw right out of the gates that this is something that was very important for us to do for the province. So we just took all of our respective professional uniforms off, if you will, and said, okay, we're healthcare providers, all of us, right? That we're in this together. This is a team. How can we best position ourselves to be where the rest of the team needs us to be? And I think there is an appetite for that across the country. I'm certain that people would be willing to have that conversation, just given that I think we're all there now, right?
Yeah. Nice. So any other questions or comments?
Just wondering, again, Mike and Phil, when your documentation is going to be available.
Yeah, was that for me?
For you or Mike?
Yeah.
Mike Sangster, Michael Sangster. Do you call yourself Mike or Michael?
Well, my mother calls me Michael, so but anybody can. So.
Right. So
okay, I'm going to go with Mike then.
There you go. Excellent.
So Mike told me about the document last time, so we'll put that up. I'll connect Mike. We'll connect afterwards and just make sure that I have all the correct ones.
And so I can say, Phil, so right now, if people are interested.
Yeah. Oh yeah, go ahead.
So I don't have the link, and I can't rattle it off for you here on this Zoom call. But if you were to go into Google and Google the term OP3, literally OP3, and NSHA, you will come up with the public policy site for the Nova Scotia Health Authority. All right. So it should say, and so if you go OP3 and then NSHA, you will come up with it. And then if you look on that policy site, on the bottom part of the bottom left-hand corner of that page, it should say COVID documents.
Great.
So, oh, there we go. Phil's got it up, right? And that is a public site. So that is not, there's no, our policies have to be available to all our patients according to Accreditation Canada. So it is there. It is available to everybody. It is free. Take those documents, and you'll see that the care directive is there. It's one of the top documents. There are also there's a document that says learning objectives, and under that there are some videos that teach people how to actually do the swab. That's
so I have one last question. Is that okay, Phil?
Yeah, absolutely.
So you mentioned rostering.
Yes.
So in most provinces, there's rostering for, as you said, beyond the dermis and an instrument in the nary and so on. So I believe we all have a variation on that theme. When you said, so people trained in donning and doffing PPE and, in doing the swabbing and so on, and you said then they were rostered, meaning that locally you had a list of people who had done that education?
Yeah, so I'm glad you asked that, because there is a point for clarity there. It wasn't rostered with our college; it was rostered in our institution. So how I went about it is we did what we call a coverage competency session anyway, because all of our PTs at our facility are responsible for covering the inpatient units and doing weekend call. So annually we do a coverage competency session. So we just scheduled one of those, and we invited our nursing colleagues to come to talk to us about what was required in the COVID assessment unit, the assessment algorithm that they use, and to go through sort of what the process was, and to also do PPE. So we did that with folks who would otherwise have to be in a place to cover on weekends or whatever. And so from that, I asked everyone who attended that session to read through and complete sort of the learning objectives or learning components of the documents that Phil just sent you. And once they were done that, they were to email me to tell me they were complete, and then they were placed on our facilities roster, of which we can then draw from. So that was the process.
So are there any physios from the community, i.e. private practices who are out of work now, or any of those folks who you've been able to draw into this?
So no, and that's a little bit more complicated, just from an HR perspective. I think it's somebody above my pay grade gets to figure that one out. I have heard across the country that different colleges are sort of putting out calls for people. And I think if we got to that place in Nova Scotia where we needed to put out a call for folks from the private sector who wanted to come and work in the public system, then we would have to determine what competencies were required and rapidly mobilize that to bring people to upskill people who maybe perhaps work primarily in a musculoskeletal way to more of a cardiorespiratory practice or other inpatient practices for that matter. So if that happens, we'll have to do that. But right now, no, we haven't done anything with private practitioners.
Thank you. You've been very patient with my questions.
Oh, great questions.
Yeah, thank you, Diana. So unless there's any pressing questions from anyone, then we'll end it there. I'm going to, just before we end it, what we're going to do with these sessions is we're going to have the Cross Canada Checkup every Tuesday, Thursday, and Sunday at 4 p.m. Eastern Time. The next one is on Tuesday with Pete Skelton, who's the head of the UK's emergency medical team, specifically for a rehab unit. But where I really want to end it is to thank you, Mike, for being here and for sharing this, and really for your innovation and leadership in this time. And what are the three names again?
Kylie Woods, Alexis Lister, and Allison Reed.
Okay, and I want to add Mike Sangster to that list as well. So thank you again for being here, and I know this will be in touch for sure, and we'll try to bring this forward.
Phil, just before you go,
Yep.
Mathieu Simard's hand is up.
Okay, thank you for flagging that. Okay, Mathieu, I think you're able to unmute yourself.
Yes, I do.
Yeah,
thank
go
you.
for it.
Work now. Thank you. So it was really interesting, and I just had two very quick points to add. I noticed in Quebec it's already underway, so there's a lot of physios who's been redeployed already to COVID-19 testing sites.
Excellent.
One of the so the tasks can be varying, but I know it's already happening on the ground. One of the questions, I found that was really interesting too, which I haven't seen a lot of discussions on, was the aspects of what are the other types of functions that physios can do, and that I haven't seen much preparation. For example, in terms of, I see a little bit with private practice, in triage or musculoskeletal for emergency, but much less so, for example, in terms of helping, for example, to clear out acute beds or the work in intensive care units. So that's quite interesting, acknowledging that it's probably going to have to come as well. and what will be the role of physios then, and how will workforce be redeployed. So that's why I was wondering if you had anything, already prepared in that aspect, or is that something that was raised already in Nova Scotia, which I have to admit I've seen less of here, at least in Quebec.
It's a great point, great question. And what I would say is I have the privilege of working with just amazing PTs who I think are ready to take advantage of, of this. Our pediatric ICU physiotherapist, Shanna Thompson, another name that should be put on the list, has been doing research on early mobilization in the ICU. And so we know that, and there's a lot been done in the adult setting, and a little less in the pediatric setting, but some. And so she's spearheading some work there. And I think there is our opportunity to improve throughput through units, right? Not discounting the need for the rehab of the ICU patient, because we do know people have associated weakness as a consequence of an ICU stay or an inpatient stay. But there is some good data from the adult literature that says that discharge from a critical care unit is faster when physio is involved and when we are mobilizing people early. So, I think if we are really at a critical level of bed utilization in an institution, 12 hours might make a difference, right? In terms of accelerating someone's discharge. So I think that is where physios, certainly that work in all capacities, but certainly those that are working in a cardiorespiratory capacity, can work to really improve and enhance the throughput on units so that there are beds that are freely available. And I think that is a major value add for us as a discipline as we go forward. So that's definitely one way. I think in a broader way, what I've said is, why would we stop innovation here? What I think it's time for us to look and say, what skills do we have from an interprofessional perspective that are the exact same as other professions? And then how can we be dispatched to do those? So a very simple example here is that we all know how to take histories, right? So is that, if we were if there was a unit, for example, I'll suggest dialysis. If we had a dialysis unit where there are very specialized skills that have to be completed by nursing, and there are 3 of the 4 nurses are sick and 1 nurse has to do it, what role could a physio or other profession do on that unit? Currently, our problem solving is, the nurses are sick, we need more nurses. I think we're moving very rapidly to a place to say, the nurses are sick, who could do this stuff, right? And I think that's where we need to think really broadly and really interprofessionally to say, we're a lot more the same than we are different. And so let's figure out where we can position ourselves. And PTs are problem solvers. PTs are particularly skilled at that. Let's step into that. Let's step into necessary, right, on those units. I think that's an opportunity for us. That's just one example off the top of my head. But I'm sure if we thought about it, we could come up with all kinds of ways where we do things similar to other professions where we could step in.
Thank you very much, Michael. And I think it's also interesting for us to already reflect as well on what will be the next steps during the emergency, because having worked many years in ICU, for example, one of my questioning is, if intubation time now average is 24 days, how will our current rehabilitation resources be able also to deal with people once the acute phase is over, and how to help them to regain autonomy and mobility? So thank you very much for that today.
Yeah, you're welcome.
Amazing. Thank you so much. And thanks again, Mike, and thank you everyone for being here. I will say that this is the longest this session has gone on. So I think it clearly shows that people are interested in what you're doing. And I love that quote, step into necessary. So thanks again for being here.
Thank you.
Okay, so we'll be in touch afterwards for sure. Thanks, everyone.
Thanks.
Okay, have a good night.